If you are a resident preparing for your broad exam, specifically the FRCS in plastic surgery, you are in exactly the right place.
Absolutely.
We are skipping the fluff today and getting straight to business. Before we begin, do me a favor, press follow on the show right now so you don't miss our future revision sessions.
Yeah, you really don't want to miss these.
And if you learned something valuable today, leave us a rating. Also, for those of you who want to take your prep to the next level, get a premium subscription to listen to the Journal Club and Clinical Cases episodes.
It is hands down the absolute best way to ensure you are fully prepared for the curveballs the examiners love to throw your way.
Definitely. So our mission today is a focused Q&A deep dive into the surgical principles of thumb reconstruction and toe transfer.
The massive topic.
Huge, heavily tested, and absolutely critical for your clinical practice. So before we get into the weeds with flaps and free tissue transfers, let's establish the baseline. What are the absolute core functional goals we must address in any thumb reconstruction?
Well, it fundamentally comes down to two main pillars, which are sensation and opposition. If you fail to restore both of these, you haven't successfully reconstructed a functional thumb.
Yeah.
You've basically just created a cosmetic appendage.
Yeah, a static coast.
Exactly. So let's look at sensation first. The thumb is our primary way of interacting with the physical environment, right? Sensation provides necessary protection from injury, like, I don't know, knowing when a coffee cup is too hot, and crucially, it ensures freedom from pain.
A numb thumb isn't just an inconvenience, it's a massive liability.
It really is.
Because if a patient has a numb thumb, they will, subconsciously stop using it. The brain protects the body by avoiding the vulnerable part.
Yeah, it effectively renders it a functional amputation anyway.
Precisely.
And the second pillar is opposition. But opposition isn't just, a single hinge movement. It requires 4 distinct biomechanical elements working in harmony. You need length, stability, strength, and mobility. If we connect this to the bigger picture, you can't have strong opposition if the thumb lacks the skeletal stability to withstand pinch pressure against the fingers.
Right, or the mobility to sweep across the palm to reach them in the first place.
Exactly.
I want to push back on that slightly, though, or at least refine it, because we know from clinical practice that not all tissue loss is an absolute functional disaster.
Sure.
You just listed length as a strict requirement for opposition. But, we see patients who lose the extreme tips of their thumbs in, say, table saw accidents or crush injuries, and they adapt beautifully without major reconstruction.
Yeah, they do.
So at what exact anatomical threshold does an amputation severely compromise hand function to the point where we need to step in with the heavy reconstructive machinery?
That is a critical clinical distinction, and it's exactly the kind of nuance tested in the FRCS. You are entirely correct. Loss of the distal phalanx may not actually lead to profound functional problems.
The brain and the hand adapt.
They adapt incredibly well. The strict anatomical threshold you need to memorize, though, is the shaft of the proximal phalanx.
Okay, the shaft of the proximal phalanx.
Right. Any amputation that occurs proximal to the shaft of the proximal phalanx is considered strictly inadequate for both pinch and power grip.
Why that specific spot, though? Like, what mechanically breaks down right there?
It is a matter of pure leverage. Once you cross that line proximally, the remaining skeletal stump is simply too short to act as a counterpost.
Ah, I see.
Yeah, the intrinsic and extrinsic muscles might still fire, but the bone cannot generate the leverage or the reach required to oppose the other digits for basic hand mechanics.
So if the amputation is at the distal phalanx, we can breathe a sigh of relief.
Usually, yes.
But once we hit proximal to the shaft of the proximal phalanx, the mechanical leverage is gone and we are in major reconstructive territory. So, since we know that anatomical threshold, we need a framework to dictate our surgical approach. Here's where it gets really interesting for exam prep. How do we categorize these defects using Lister's classification, and exactly what treatment is dictated for each?
Right, so Lister's classification is the gold standard framework because, well, it rationalizes thumb defects into 4 distinct categories based on structural loss. Let's build this logically, starting from the surface. Type 1 is defined as having acceptable length, but poor soft tissue cover.
Meaning the skeletal foundation is intact, but the biological envelope around it is compromised.
Exactly. Because the bone length is acceptable, your entire treatment arsenal is focused purely on coverage and maintaining sensation.
So what are the options there?
The options dictate a stepwise approach depending on the size and location of the defect. For minor tip loss, you can allow for healing by secondary intention or perform a simple revision amputation to get primary closure.
And if we need flap coverage?
Then we look at local options. You can use VY advancement flaps, which involve cutting a V-shaped island of tissue, pushing it forward, and closing the donor site as a Y to, recruit lateral tissue.
Let's visualize that for a second. For larger volar defects, we can't just push a small VY forward. We need more surface area.
Right. In that case, you escalate to the Moberg volar advancement flap.
The Moberg?
Yeah. You make midlateral incisions along both sides of the thumb, elevate the entire volar skin along with its neurovascular bundles, and slide it forward.
It's essentially like pulling a hood over the exposed tip of the thumb.
That's a great way to picture it.
And what if the local tissue is completely devastated and we have to, I don't know, borrow from neighboring fingers?
Then you look at regional flaps.
Right.
For exam purposes, you absolutely must remember the first dorsal metacarpal artery flap, or FDMA flap.
The FDMA?
Yes. This was specifically described by Fucher in 1979, and it brings a kite-like island of skin from the dorsum of the index finger over to the thumb.
Oh, wow. Okay.
And finally, for sensate coverage, there is the littler heterodigital island flap, which tunnels a neurovascular island from the ring or middle finger. All of these are your type 1 treatments.
Excellent. Acceptable length, fix the cover. But let's raise the stakes a bit. What about type 2?
So type 2 is a subtotal amputation with questionable remaining length.
Questionable length, meaning it's hovering right at that critical leverage threshold we talked about earlier, the shaft of the proximal phalanx.
Yes, it is very borderline. The stump is just a bit too short to be highly functional, but not so short that we need to import a whole new digit.
So what do we do?
The elegant treatment algorithm here doesn't necessarily involve adding tissue to the tip. Instead, the simple direct treatment is deepening the first web space to relatively lengthen the stump.
Wait, how does deepening a web space create a longer thumb?
It's an optical and biomechanical illusion, really. By surgically releasing the adductor pollicis fascia, or using a Z-plasty to drop the web space closer to the wrist, you expose more of the existing thumb metacarpal.
Oh, I see.
You aren't actually lengthening the bone. You are just freeing up the buried portion of the skeleton to improve grasp and opposition.
I love that. You aren't building a new room on the house. You're just knocking down an interior wall to make the hallway longer.
Exactly.
Okay, let's keep escalating. Type 3.
Type 3 is where the structural collapse happens. This is a total amputation of the thumb, but crucially, with a preserved carbometacarpal joint, or CMCJ.
Preserved CMC joint.
Right. Because that foundational joint is intact at the base of the thumb, the ideal gold standard treatment here is the free toe transfer.
The ideal. But, in a Viva situation, examiners will always ask for alternatives if a toe transfer isn't possible.
Always have your backups ready. Alternatives for type 3 include metacarpal distraction lengthening, where you slowly stretch the remaining bone over weeks.
Okay.
You could also do an osteoplastic reconstruction, which involves taking an iliac crest bone graft and covering it with a soft tissue flap like a groin flap.
Right, right.
Or, alternatively, you can perform a pollicization of an injured or partially amputated digit if the patient happens to have one available.
Which naturally brings us to the ultimate foundational failure, type 4.
Type 4 is a total amputation with the complete loss of the CMCJ.
So no joint at all?
None.
No.
The treatment here is pollicization, usually taking a fully functioning index finger and repositioning it as a thumb.
Let me pause right here because this is a conceptual hurdle that trips up a lot of residents. Let's unpack this. Why exactly do type 3 and type 4 dictate such radically different ideal treatments based purely on the presence or absence of that CMC joint? Like, why is a free toe transfer ideal for type 3 but considered completely off the table for type 4?
It goes back to our very first core principle, opposition.
Right.
Opposition requires mobility. The CMC joint is the universal joint of the thumb. It provides that massive arc of rotation and multi-axial mobility.
It's the engine.
Exactly. If you have a type 3 defect, that universal joint is still sitting there in the hand. If you transplant a toe and fix it onto that joint, the new toe will be able to move, sweep, and oppose.
Makes sense.
But in a type 4 defect, the CMC joint is completely gone. If you stick a free toe transfer onto a rigid carpal bone like the trapezium or scaphoid, it will just sit there.
It will be a static post.
It won't move at all. Pollicization, however, takes a functioning digit with its own intact joint system and muscles and moves the entire unit into the thumb position, bringing the required mobility engine with it.
That makes perfect sense. If the mobility engine is gone, you have to import a completely new engine, not just a passenger.
Exactly.
Okay, let's isolate that ideal treatment for type 3 amputations, the free toe transfer. The ultimate goal here, mathematically speaking, is providing a thumb and two fingers to achieve a functional tripod pinch.
Right.
Okay, let's unpack this. Think of the blood supply to the toes like a highway system with two completely different routes. How do we determine which route to harvest?
What's fascinating here is the sheer variability of the anatomical wiring.
Mm.
Most toe transfers are going to be based on either the lateral digital artery,
For the great toe, right?
yes, for the great toe, or the medial digital artery, if you're taking the second toe. But those digital arteries arise from two entirely different highway systems in the foot.
The two different routes.
Exactly. The dorsal arterial system, which
Mhm.
comes from the dorsalis pedis artery, and the plantar arterial system, which comes from the plantar metatarsal arteries.
And as a surgeon, you can't just guess which one is driving the blood supply to that specific toe.
Absolutely not. Determining which system is dominant is the absolute key when harvesting a toe.
It's life or death for the flap.
It really is. If you dissect out the dorsal system, assume it's the main supply, and blindly ligate the plantar system, only to find out the plantar system was actually dominant, you've just killed your flap before it even leaves the foot.
Oh, wow. So what are the strict dominance percentages we need to quote to the examiners?
You need to know these numbers cold.
Mm.
The first dorsal metatarsal artery is dominant in 70% of cases.
70%.
Right. The first plantar metatarsal artery is dominant in 20% of cases.
Okay.
And in the remaining 10% of cases, both systems are of equal caliber.
70 dorsal, 20 plantar, 10 equal. But wait, if guessing wrong means the flap dies, how do you actually figure this out on the operating table without ruining the tissue?
You have to test it dynamically in vivo. Surgeons will typically use a microdoppler probe directly on the vessels to listen to the flow.
Right.
More definitively, we use selective clamping. You place a temporary microclamp on the dorsal system and watch the toe. If it still has brisk capillary refill, you know the plantar system is doing the heavy lifting.
And if it doesn't?
If the toe immediately turns white, the dorsal system was dominant.
It's high-stakes plumbing. And we can't forget the return flow and the wiring.
Right. To complete the anatomical picture for the harvest, most of these transfers are harvested with a superficial dorsal venous system for venous drainage. And for that critical functional goal of sensation, the plantar sensation of the toe is supplied by the plantar digital nerves, which must be meticulously coapted to the recipient digital nerves in the hand using microsurgery.
Knowing the vascular plumbing is only half the battle, though. Selecting the correct variant of toe transfer for a specific clinical presentation is the other.
Very true.
The exam won't just ask you how to do a standard great toe transfer. They will give you messy, real-world constraints. Let's run some rapid-fire scenario Q&A.
Let's do it.
If I need to reconstruct a thumb, I go for the great toe. But what if the donor site is unacceptable to the patient or I'm operating on a child? Let's start with the unacceptable donor site.
Well, the great toe transfer is ideal for the thumb, but if the great toe donor site is refused, I would offer a second toe transfer.
Why the second toe?
It can successfully reconstruct a thumb, and patients are often much more accepting of the donor site morbidity because losing a second toe is less visibly shocking.
Are there downsides?
Definitely. Disadvantages include a tendency to claw over time as tendons scar, and it leaves a bulky teardrop-shaped pulp that doesn't perfectly match a natural thumb.
Okay, what if they want the beautiful aesthetic match of the great toe, but they don't want to lose the whole skeletal structure of their big toe?
Then you would use the wraparound technique. You take the great toenail, the skin envelope, and an iliac crest bone graft from the hip.
So you just wrap the toe skin around the hip bone?
Basically, yes. It gives a smaller, much more aesthetically pleasing thumb and preserves the skeleton of the donor foot.
But there's a catch, right?
Yes. It doesn't restore joint mobility because you are using a static bone graft, and crucially, it is not used in children.
Why not in children?
Because an iliac crest bone graft lacks the capacity for longitudinal growth. The growth plate of the toe was left behind in the foot.
That is a phenomenal exam point. Okay, new scenario. I want the joint mobility of a full toe transfer, so I need the joints and the growth plates, but I want the refined aesthetics of the wraparound.
That requires the trimmed great toe transfer. Harvested conventionally, but you perform a longitudinal osteotomy to remove a strip of bone from the side of the phalanges, and medial soft tissue is excised to perfectly match the intact thumb.
Incredible. Let's pivot to fingers. Severe distal soft tissue loss of an index finger.
For that, you use the second toe wraparound. But specifically for fingers, you must include the distal phalanx bone to prevent pulp instability and nail deformity.
What if we need multiple digits?
Combined toe transfer, second and third or third and fourth toes. It provides a web space and is supplied by a shared pedicle.
When would you ever use an isolated third toe transfer?
Rarely used.
Yeah.
Only if the second toe isn't available.
What if I just need a joint? Destroyed PIPJ or MCPJ?
Vascularized joint transfer from the second toe, based on articular branches from the medial digital artery. Gives limited range of motion, but is stable, durable, and can grow.
And if I just need skin, no bone, no joints?
Neurosensory-free flaps. Grade toe-free pulp flaps for sensate skin, closed primarily, or first web space flaps for thin sensate islands.
So what does this all mean for the patient's foot? How do we manage expectations and close the donor site?
Sequelae of the toe harvest must be discussed in absolute detail. Patients should actively be shown photographs of feet following a toe harvest.
No surprises.
None. And the donor site itself must be closed primarily with minimal tension.
Right.
This raises an important question regarding long-term function. Most patients do not have problems walking.
But they might have issues with running.
Exactly. They may experience fatigue when playing ball sports, anything requiring explosive push-off from the forefoot.
Which is a perfect place to wrap up. To all the residents listening, if you want something clarified from today's deep dive, drop a comment or a question below. As you prepare for your exam, consider this tension in surgical planning. If your patient has a Lister type 3 amputation, where a free great toe transfer is the ideal treatment, but their primary passion is playing high-impact ball sports, how do you balance the ultimate thumb reconstruction against the guaranteed foot fatigue? Which compromise do you offer? Good luck with your studying.